Today we'll be talking about understanding birth defects, which is something a lot of people don't know a lot about, and there's a lot of stigma about it. Thank you, Dr. Uwajeh and Tonye and Darwans for coming on the program to help us understand birth defects better. Dr. Uwajeh, it's always a pleasure to have you here with us. Can you tell us, what are birth defects?
Well, just the layman terms, it just means some anomaly that occurred while the baby is still developing and may be manifested at the period when the child is being born or later on in life. So something could have happened. It could be as a result of chromosomal anomaly. So when the chromosomes are coming together, or for some reason we don't even know why. And then there's certain things that maybe a pregnant woman could do during pregnancy, or even towards getting pregnant, that may make them more prone to getting, having a child who has a birth defect.
What causes birth defects?
Okay, so as we said, the large number really of congenital anomalies, we don't know why it happened, But one thing we know, if, for instance, when the sperm and the egg, when it's coming together and it happens to result in something that is not, we'd say, compatible with life, the body has a way of expelling it. All right, so, and that's, what happens usually in the first trimester of pregnancy. So quite a number of abortions, so to say, that happens usually in the first trimester. Most of the time, it's because, the fetus that is being formed is not compatible with life. Then, because, we're all made up of what we call chromosomes, 46 XX or 46XY. If you're a male, you're 46XY. Female, you're 46XX. Now, because for all of us, each of us, we get half of that from each of our parents. So if there is something wrong in any of those strands that you're getting from either, your dad or your mom, then there is a chance that that child could have some form of birth defect. And then, as I said, there are a lot that, structurally, that means as the baby is developing, those things could happen. For instance, with development of the brain, most obstetricians will tell their, parents or the patient as they're trying to get pregnant, you need to take folic acid. We have studies have shown that low folic acid could make the child have what we call spinal bifida. All right, so, and so many other things. And then we know also that as the mother gets older, the maternal age could also make someone more prone to getting children with birth defects. All right, and then there's some other underlying medical conditions, like somebody who has diabetes, they're more prone to getting those. So all of those must be properly and well controlled, as one begins to think about getting pregnant.
Talking about birth defects, can you tell us a few of them? How are they formed?
As we said, some of them, yes, could occur at inception. All right, so when either, the chromosome coming together, if they're not of the right size or one of them is missing, that could result in some form of a congenital anomaly or birth defects. And then there's some enzymes or, some protein that could be missing. Sometimes we say that, the mother or the father could carry the traits. And therefore, with that, the child could end up with some kind of congenital anomaly. I mean, congenital anomaly, the most common ones, that we see, apart from just the physical ones, things like congenital heart defects. A lot of people, even now in developed countries, they've known that, just making, what is it called now? Just having a routine pulse oximeter, we can detect those, And then, of course, there are infections. If a mother gets an infection while, there's what we call the touch infection, someone like congenital rubella, for instance. If the mother gets a rubella infection while pregnant, they're more prone to getting a child with a congenital birth defect. Of course, if you smoke, you run the risk of having a child with birth defect. If you use drugs, IV drug users, things like that, could make you more prone to having a child who has birth defects.
Is there any way a mother could know that, for example, if she was pregnant, if she could know that her child had a problem?
Right now with pregnant women, amniocentesis are done, when they have cultures of the amniotic villi, just to see the sampling, and that way they're able to detect first if there is any kind of congenital anomaly. But even just routine ultrasound, it's able to help us to find out, if the child is growing well, if there structurally is anything wrong with the brain. So many of these congenital anomalies even are picked up before the baby is born, so that the parents, the doctors, and all of them are prepared that, something could be wrong with the pregnancy. Even during pregnancy, the amount of amniotic fluid, the amount of fluid that's surrounding the child helps the obstetrician to know, if this child is going to have or may actually be developing some form of birth defects, and apart from even, as I said, during pregnancy, even immediately after pregnancy, we're able to have tests done to see if there are any form of congenital birth defects going on with the newborn.
How are birth defects diagnosed?
There are a number of ways that a child with birth defects could be picked up. First of all, it's important when the baby is born that the child is examined by a pediatrician. At that time, there are a number of things that the pediatrician looks for in terms of is there a murmur? Can they look at the eye? Is there a red reflex? Is the size of the head, is it the right size? Okay, do they hear a murmur? Are all the pulses present? So just a very, very good physical exam, all right? Can you see when you look at the umbilical stump, do you see 3 vessels? Is there a club foot? Just physical exam that could make them to know that, look, something is just not right. Maybe we need to do something a little more. Murmurs, for instance, will make the doctor to insist to have an echo. When they have that, they're able to detect it even a little more. They could have chromosomal karyotype done after the child is born, especially if the child looks, the facies of the child looks abnormal. So that by itself will let them know that something is definitely not right. Another thing that we don't routinely do in Nigeria will be a newborn screening. All right, when we do that, it's able to help us to detect certain birth defects in children. And that also goes a long way, at least in developed countries, to help them in terms of getting to know if this child has any form of developmental anomaly. And immediately, and then 2 weeks after birth, the child really should be seen by a pediatrician, so that if anything was missed at delivery, it can also be seen at that time. And of course, the routine well child care that the child takes also allows, because there are some murmurs, for instance, that you wouldn't even hear at birth, and it's after a certain number of months that it begins to manifest, or you just realize that this child is not thriving well. What is going on? And then you realize that, maybe there is, overwhelming infection. Could it be a posterior urethral valve? Do I feel a mass in the abdomen? Those kind of things will help us to know, okay, is there a birth defect? Is there a congenital anomaly and then to investigate it further.
Thank you so much, Tonye, for coming on the program and sharing your experience with us. It's really appreciated.
Thanks.
So can you tell us about your child? What happened? How did you find out the child had a problem? What was it? And what have you done about it?
Well, my daughter Simone I have two children. She is the younger child. She's 6 years old now. It wasn't until we got back to Nigeria. So I had her in the US. And so for the first 8 weeks, she was there. Then we went a month in the UK. And then at 3 months, we now came back to Nigeria. Everything was fine. Nobody observed anything. There wasn't any issue. In fact, her pregnancy was easier. Delivery was easier, even though I didn't have anesthesia than with her brother, who's about 20 months older than her. So it wasn't until we came back and I noticed she wasn't really adjusting well to the climate. She was still sweating. She hadn't, the rest of us had adjusted and she was still kind of profusely sweating. But I was like, maybe she's just taking a little bit more time. But then we had a choking incident with her and I knew the baby first aid and I was able to support her through that. And then I took her into pediatric partners to see them. And it was Dr. Sanusi who, in our follow-up appointment, just to check on her, make sure everything was straight, now was just, she just couldn't put her finger on it, but she was like, she wanted to test her for Down syndrome. And I was quite taken aback because then she didn't really look like she had Down syndrome. She didn't present a lot of the typical things. She didn't have the simian lines. She wasn't really floppy. She wasn't so obviously Downs. So I was a little surprised, but I said, okay, go ahead. And it came back that she had Down syndrome, which was a real shock. And then it was kind of a roller coaster from then because I always thank pediatric partners, and that's why I'll never leave them, because very honest, very direct, they really have the children's welfare at the center of what they do. So immediately, she didn't give us time. We weren't, it wasn't like, oh, you should have done this, or you should send her to a home or send her away. They're useless, all the typical things that most parents would hear in this environment. She was the complete opposite. She was like, it's not the end of the world. This is what you do. Because, some of them have heart issues, you need to do immediately, as soon as possible, do an echo. So she sorted that out and gave us a pamphlet. Now, this is what Down syndrome is. This is what you need to do. We're going to schedule a physiotherapy session so that she can get assessed by a physiotherapist. So we were like, okay, we're going to do this. Yes, we were upset. Yes, we cried. But she already put us on a path of actual action. And as over the years, I've come to understand why. But unfortunately, that's not really what happens most of the time. So it was, I think, 5 days after that diagnosis that we had the appointment with, again, another person I credit for saving my daughter's life, apart from pediatric partners, which is Dr. Magic Adumi, Dr. Tosin Magic Adumi. And again, I don't know if it's a format that you guys have where you don't sugarcoat things. But again, we went for the echo and she was only 4.5 months at this time. And he started the echo and within a couple of minutes, he said, I'm going to have to put her to sleep. I need to see more. I need her still. And with that, I already knew, this is bad. This is bad. So I sat there quietly and he did his thing on the echocardiogram and took me through it afterwards. And long story short, he basically said she was in heart failure, that he doesn't know how she wasn't presenting symptoms other than the sweating. Because most children in the condition that she was would have been kind of blue lips, gray, pallor, and she wasn't, and she looked fine, which also was a cause for concern. The fact she looked fine, but internally she was, he gave her a maximum of 6 months to live if we didn't do anything. So it was a real shock. I wasn't expecting it. And to be honest, at that point, Down syndrome did not even matter. you can't tackle Down syndrome if the child is dead. So he said they do heart surgery, but nothing like what she needed here in Nigeria. That our best thing was to get her where we could get what she needed ASAP, that this is a life and death scenario. So again, I always appreciate direct talk, no sugarcoating, because you don't waste time. And then we went to the US, and we went back to the US, and immediately, you know, from landing, they took us into the hospital. They didn't allow us to go home. It was they explained to us how ill she was, and that she wasn't even well enough for the open heart surgery. So that's really how we got the diagnosis. It was a complete life-changing experience. But you know what I always say to people is that how you get the diagnosis is what sets the tone of your journey. And I'm just always appreciative of how we got our diagnosis, in that it's not the end of the world, that your child can have a good life, that you just need to do things now to ensure that she reaches her potential later.
That's wonderful. Thank you so much for sharing that. I really appreciate that, and the positivity. It's really encouraging. That's what I'd say, really encouraging. Thank you. Darwan, thank you very much for coming on the program. Can you share with us briefly your experience? What happened? What diagnosis your child has? How did you find out? And what have you done about it?
Okay, thank you very much. So my son is going to be 15 months tomorrow. And I remember when I gave birth to him in October 2020, I was telling my mom that this child's tummy looks unusually big. And she said, oh, well, maybe he's eating a lot and all of that. So we just talked about it. And I remember also that when we went for our 6-week immunization, I complained to the doctors there. And then they said, oh, you're probably not burping him well. So they did that thing where they tapped the baby's tummy with their fingers. And the doctor said, oh, you're probably, and I'm a second-time mom. So I figured, how difficult can it be to burp a baby? But I really didn't say anything. So I went home and, life continued. But I just noticed that at 4 months, my son started having these temperature spikes. So the first time he had this temperature spike, we took him to the hospital, and then they said he has malaria. And I'm like, malaria at 4 months? Well, they did the test. And then, like I said, I don't think there's anybody in Nigeria who has Nigerian blood that doesn't have some form of malaria in them. So of course they did the test, and he had some malaria parasites and all of that. So he was treated for malaria. But I found this strange that a 4-month-old would be down with malaria. The next month, we're back in hospital, another temperature spike. And I'm talking about temperatures 39 degrees and above, 39 degrees centigrade and above. So the temperature spikes were so frequent, and so like they were back to back. So of course, we kept going in and out of hospital. It would be malaria infection, one antibiotic after the other. But I kept saying this child's tummy is unusually big. And every time we went to the hospital, I would complain about his tummy. We even did a scan, interestingly. A scan was done, but call it mother's intuition, I still knew something was wrong. And then I started Googling. Now, this sounds funny because the first time I Googled, I came up with a very funny diagnosis. Dr. Uwajeh will laugh at me when I say this. So I was telling my son that I think my husband, that I think my son has Hirschsprung disease, because he had this unusually large tummy that looks like a pineapple. It was wide in the middle, narrow at the top and narrow at the bottom. So by the time we had all of this going back and forth to hospital, and then the last episode that ended us in hospital, I noticed that anytime he wanted to urinate, he was crying to urinate. At first, I thought it was a bowel movement. But when I was able to do some elimination, I noticed that it was actually urination that was causing the crying. So I figured there's no point going back to that hospital. I think we need to see a specialist this time. So really, that's how we ended up at Pediatric Partners. And the day we got to pediatric partners for the first time, it was a Saturday evening. I just told them that I think my son has a UTI because he's urinating with pain and all of that and all of that. I didn't even mention the tummy thing. I just figured, let's sort out what is on the ground. And we had run some tests. I was sitting in the reception area waiting for the results of the test. And then Dr. Uwajeh was passing. She passed us. And then she turned and she said, this child's tummy is unusually big. This doesn't look normal. I was like, oh my goodness, God, somebody's finally seen what I've been seeing all these months. Like, I literally, it was like someone just poured cold water all over me the minute she said it. I was like, wow. And she turned around and she said, oh, let me take a look at him. Then she took a look at him and said, oh, I really can't say what's the problem is now, but we need to do some tests. So that was how we went for a KUB scan, which is kidney, urethra, and bladder scan. And after some back and forth, we came up with a diagnosis that he had PUV, posterior urethral valve. Apparently, there are a couple of valves that are at the entrance or at the junction between the bladder and the urethra. So during pregnancy, those valves are supposed to be absorbed into the body. But for some reason, in my son's case, they weren't absorbed. So they ended up as vestigial tissues. I think that's what they call them. So they were there and they were causing an obstruction. So he had trouble passing urine. And because of that, he had backflow. So urine was flowing back into his kidneys. So his kidneys were waterlogged in layman terms. His tubes were also had a lot of water in them, so all of that just led to a kidney infection. So we were billed to have surgery to clear out that obstruction, but while we were trying to sort out the process to get the surgery, he came down with a kidney infection, and we battled that kidney infection for almost 3 weeks. Like, we kept going from one antibiotic to the other. Like, it was just a really terrible time for us as a family, really. But eventually was able to come on top of the infection. And then we had the procedure to clear out the valves so that he could pass urine freely. And all of that pain wasn't there, the crying and all of that. But it took us almost 11 months to get to this point. And then I feel bad because I feel like I was being told that this was something that could have been picked up when I was pregnant, like during antenatal scans. So I just feel bad, like this whole thing lingered and we didn't notice it until he was almost a year old. So really, that's my story.
Thank you so much for sharing that. And I think what is important is that it has been picked up and you've treated him.
Yes.
And he's better now.
Yes,
I think that for me is the most important thing. And I think what is important out there is to let people know that if there's an intuition, particularly if there's an intuition in a mother, and you feel something is wrong, don't stop. Don't stop until you find out what it is and you have your mind settled. Question for you, Dr. Uwajeh. Can birth defects be prevented? If so, how?
Thank you so much, Dr. Pamela. Yes, certain birth defects could be prevented. For instance, as I said, spinal bifida, neurotube defects could be prevented by the mother taking folic acid, which is a B vitamin. And we prefer that a woman who is desiring to get pregnant starts taking it before they get pregnant. This has been shown to prevent spinal bifida or neurotube defects. Okay, and making sure you don't take alcohol, making sure you don't take drugs, especially street drugs. When we say drugs, we mean street drugs. These are things that makes you more prone. And therefore, if you don't do that, then yes, we can prevent birth defect. But there's some that, we just cannot prevent. Because why they happen, how they happen, a lot of people, research is still out there. We just don't know why.
Does alcohol and smoking cause birth defects?
Oh, definitely. It's been shown that when you smoke or you drink during pregnancy, that you're more prone to having a child with fetal alcohol syndrome, all right? And those kids end up with a small brain, developmental anomalies and things like that. So yes, smoking and drinking has been shown to have a higher correlation with having a child with birth defects.
Can stress during pregnancy cause birth defects?
I'm not aware of that, but when you're under stress, so many things could happen. Your blood pressure could go up, therefore resulting in reduction in blood flow to the child, and therefore preventing essential nutrition from getting to the child. So yes, stress resulting in high blood pressure and, all of that could actually result in a child that would not be optimally, or the baby that would not be optimally developed.
Question for Tonye. What would you like to see set up in this country to help children with special needs?
So we actually need to go further back and really educate or inform at a much more foundational level. And I believe the best way to do that is through media, through the visual image, just including with people with disabilities and special needs in general discourse, in the content we see, in the content we hear, in the talent pool, in the books we read. And that way it fosters a bit more understanding and acceptance. Therefore, moving forward, employment areas, when they become adults, when you put on all this work that we've done in early intervention and sending them to school and making sure they get to their best abilities, but then there's no jobs for them. They're not taken seriously in their vocation. And these are people that love responsibility, that want to be contributing members of society. And when you look at statistics, they actually help to bring to better the society. And they also help to empower their fellow students. If they're in school, statistics show that it benefits not only the special needs child, but it benefits the neurotypical child as well. So we really have to go back to the foundational elements of just exposing people to people with disabilities and special needs.
Thank you. Question for Darwan. Can you tell us how common is posterior urethral valve? Do you know? And what did you think when you found out your child was the one who had it? What were your emotions?
Okay, so I've been told by the doctors that PUV affects 1 in 8,000 boys. Now, when I heard that, it was a very interesting statistic, because not just children, now we've removed all the girls. Now we're looking at 8,000 boys. In 8,000 boys, it just had to be Iyanoluwa Kiton that had PUV. I sat down and I said, God, why me? Like, there's no sugarcoating it. I said, why did it have to be my son, 1 in 8,000 boys? It was a really tough situation for me. But then I looked at it and said, well, if not me, who? And this has really been an interesting experience for me. It's been eye-opening. It's just made me see like life in a different way, because there's no telling what you would do as a parent until you see your child at that point where they're between life and death, and you're just helpless to help them, or like you really don't know how to go about, because you feel like you would always be there to protect your child, to be there for them, to guide them, to guard them, and all of that. And then you're just in this helpless space where you're watching, and there's tubes coming out of every part of every orifice in his body. There's machines to him and all of that. So it was a terrible experience. It's not one I want to relive. Absolutely not. But I thank God that the worst is over. And we've been told that posterior urethral valve is a journey. His kidneys took a hit. So his kidneys are going to take some time to recover from all of that backflow that he had, even as a fetus, then before he was born. So we've been told it's a journey that we should be patient. We shouldn't expect anything to happen suddenly or overnight, but that we should just be prayerful, we should be hopeful, and we should keep our hospital appointments so that, because he needs constant follow-up. His creatinine levels have to be monitored frequently, periodically, and so many other things that have to be checked periodically too. So we're just trying the best that we can do as parents to help him get a good start in life. And then, of course, because of the situation, he was labeled as failure to thrive. Now, when they say a child has failure to thrive, or failure to thrive basically means that the child is less than the ideal weight or the average weight that they're supposed to be for their age. So with the help of Dr. Uwajeh too, we've been on a nutrition regimen to help him get to his proper weight. But developmentally, he's meeting his milestones. Like, he started walking at 14 months. He'll be 15 months tomorrow. So he's walking, says a few words, and so I would say for that he's okay. So we're trying to get his weight to up so that we don't have that failure to thrive problem.
Well, thank God.
Yes.
Thank God. Dr. Uwajeh, can you explain what failure to thrive is, and how often would you find birth defects in a child with that condition?
Okay, well, even now, we're now being told that we shouldn't use the word failure to thrive anymore. That we should use things like, not meeting the percentile, But basically what it means is that this particular child, there is a norm. All right, there is no ideal weight, but there is a norm. You could either be from the 3rd to the 97th percentile. All right, that means that, we've taken a census of what we think the weight or the height or the head size of at a particular age. And we're saying that this range is considered as normal. So for us, if you're below that, or we think that you were on a particular percentile, that's what we call that, and you're now falling below that, then you're not getting to your ideal weight. Failure to thrive by itself does not mean that the child has a congenital anomaly, but we know that for some kids, just if you remember what Simone's mom said, she was sweaty, all right? That means that she was using a lot of energy, and she would, some parents would even say, when this child sucks, they will take their mouth away and be huffing and puffing, just trying to catch their breath, okay? That child is using so much energy because there is something congenitally wrong. And therefore, because of that, that child is not getting to the ideal weight. In the case of our other patient, Yanolua, the repeated infections because of the backflow of the into the kidney, hydronephrosis, hydroureters and all of that, makes him not to be able to gain weight as adequately as he should. So yes, for a child who is not meeting their milestones, first, we want to be sure that there is no cardiac anomaly. So, for some of them, if you hear a murmur, or even just by examining, you could say, or we compare when we do a physical exam, we compare blood pressure and different, the different limbs, you're able to say, something looks like it may be wrong congenitally with this child. And that might be the reason why this child is not getting to the ideal weight that we want the child to get to.
Thank you very much. Dr. Uwajeh, so with these two cases, do you have any comments? Unfortunately, time is fast spent and we have to wrap up now, but do you have anything you'd like to add to what they've said?
Well, thank you so much, Dr. Pamela. And I really want to thank our parents for coming out and actually letting everybody know that, these defects are there. Basically, as both of them, my going out comment would be, first, get a good prenatal care. Make sure you take all your medications the way you should. All right. Make sure that your doctor is aware of whatever medications you're taking. All right. And take them the right way. Also, just as both our parents, if you think something is wrong with your child, please take the child to see the doctor and never stop. Don't stop until you think that you have the answer. Don't let anyone just, tell you to go away. All right. But, it's important before pregnancy, during pregnancy, after pregnancy. Even there are some birth defects that are, detected much later in life. There's some that we're able to pick up almost immediately. Others, like Simone, for instance, was fine, nothing at all until, she had the heart failure. So that would be my, my point. So,
Thank you. One of the things I'd also want to stress is there should be no stigma to this. There's no stigma. There's, these things happen, and there's nothing to be ashamed of. There's nothing to hide. But the most important thing is to get the best care that you can get for your child.
And the care is out there, even in our public hospitals. There are excellent doctors doing wonderful things. There are NGOs that are repairing cleft lip and cleft palate. So many help that's out there. Please don't hide these children. They have good potentials, and they have great ones ahead of them.
Dr. Ajayi, I just want to say one more thing. I know you're wrapping up. And just as a parent, just to say there's no shame. You should not feel shame. There's no shame in this at all. You don't have to hide your child because they're ill. You don't have to keep them away. It is difficult, and you will grieve for the child you thought you were having, but you must accept and love the child you have. And if you want that child to flourish, what you put in is what you get out. So you must love the child. They flourish, they get better in an environment of love. It's not about money. Yes, money helps, but at the end of the day, love is what heals. And so if you can surround them with a village, because it can't just be you, you have to ask, you have to speak up, and you have to ask for help. And sometimes it may not be family members. Sometimes it may be a friend or a colleague that sees you, and because you shared that struggle, there is no shame in it. So that's what I want to say. Yes, it's really, really important as parents to understand that. And that's why I do my work as a special needs advocate, why I speak up for my daughter and other children who have disabilities and special needs. And so we have our platform, Simone's Oasis, directly aimed for that. Representation matters. So we represent not only the Black African child, but we represent our special needs children. And the more parents, the more people, the more citizens of our country that can see that these children can flourish and just be who they are in their environments, the better we'll all be for it.
Thank you so much.